All right, let's jump right into this. Welcome to today's Explainer, where we're tackling a topic that touches almost everyone's life in some way: breast cancer. Think about this for a second. In the year 2020, breast cancer actually became the most commonly diagnosed cancer in the entire world. It even surpassed lung cancer. Our sources estimate that about 2.3 million new cases are diagnosed globally every single year. The sheer scale of this disease is absolutely massive. But you know what? So is the scientific progress we're making against it. Today, we're going to break down the science, the symptoms, and the survival strategies, taking you all the way from microscopic cells to the modern therapies that are saving lives right now. Here is our roadmap for today. We're going to start by looking at the global scale, zoom way in to check out cellular development, dive into genetics and risks, and then transition over to screening and symptoms. Finally, we'll decode the various subtypes of the disease and wrap up with the really hopeful part: modern treatments. Okay, section 1, the global scale. So the most staggering statistic we're facing here is this: 1 in 8. That means roughly 1 in 8 women will be diagnosed with breast cancer in her lifetime. Just let that sink in. And, while it definitely predominantly affects women, guys aren't completely immune. Men actually make up about 1% of all cases too. Because this condition is just so remarkably common, understanding how to prevent, detect, and treat it is absolutely crucial for every single one of us. Now, this is definitely not a new enemy. We're talking ancient history here. The very first known mention of breast cancer actually pops up in Egyptian medical text from way back around 3000 BC. Fast forward to 400 BC, and Hippocrates, the father of clinical medicine, he was blaming the disease on an imbalance of blood, phlegm, and bile. So obviously, we've come a very long way since then. But if you look at the timeline, it really wasn't until 1894 that we hit a major turning point. That's when a surgeon named William Halsted performed the first radical mastectomy at Johns Hopkins. It's a huge gap in time, right? It just goes to show that while this disease has deep, ancient roots, our medical understanding and surgical techniques have literally exploded in just the last century or so.
All right, moving on to section 2, cellular development.
So how exactly does a perfectly healthy cell turn into a deadly tumor? Well, it's a step-by-step pathophysiological progression. The breast is essentially made up of lobules, which produce milk, and ducts, which carry it. Everything starts out completely fine with normal epithelial cells in these areas. But over time, if DNA damage builds up, these cells might mutate and become abnormal. We call this in-between state atypical hyperplasia. Think of this as the body's warning phase. If they keep mutating, they can completely crowd the ductal lobule, becoming what's called a carcinoma in situ. Now, in situ basically just means it's still confined. It hasn't broken through that structural wall called the basement membrane. But if it picks up even more mutations, releasing enzymes to literally chew through that membrane and hijack its own blood supply, that's when it becomes an invasive carcinoma. It's now fully capable of spreading. There are two main starting points for this cellular mutation. Ductal carcinoma is by far the most common, accounting for the vast majority of cases, and it starts right in those milk ducts. But contrast that with lobular carcinoma, which kicks off in lobules. And what's really fascinating, biologically speaking anyway, is how lobular cancer spreads once it turns invasive. These cells actually lose a specific binding protein called E-cadherin. Basically, they lose their cellular glue. Because of this, when they migrate past that basement membrane, they actually march out in this incredibly distinct single-file line. Now, the really crucial thing to understand is what happens when these invasive cells get truly mobile. When tumor cells break away, sneak into the lymphatic system or the bloodstream, and basically set up camp in distant organs, that's what we call metastatic breast cancer. Often they'll travel first to the nearby lymph nodes right under the armpit, but once they hit the bloodstream, they frequently migrate to the brain, the bones, the liver, and the lungs, which causes immense systemic havoc. We're talking things like bone fractures or severe neurological deficits. This right here is the true biological danger of the disease. Which brings us to section 3, genetics and risks. Let's talk about risk factors. Look, every single time a cell in the breast tissue divides, there is a tiny, tiny risk of a DNA copying error, a mutation. And estrogen is a hormone that naturally tells breast tissue cells to multiply. So it makes sense that prolonged exposure to estrogen over a woman's entire lifetime significantly bumps up her risk. We've got non-modifiable risks that increase this exposure, things like getting your first period at a very young age, or going through menopause late, or even nulliparity, which is just a medical term for never taking a break from menstrual cycles through pregnancy. But we also have modifiable risks, things we can actually change. For instance, fat tissue contains an enzyme called aromatase that converts other hormones into estrogen. Because of that, obesity is a major modifiable risk factor, and so is heavy alcohol intake. And then, of course, there are the genetic triggers. Normally, if a cell's DNA gets damaged, your body's tumor suppressor genes swoop right in to fix it. BRCA1 and BRCA2 are two of these superstar repair genes. But if a patient inherits a mutation in these specific genes, that critical repair system basically goes offline. The DNA damage goes completely unchecked, allowing the cells to mutate and multiply like crazy. Patients with these BRCA mutations are at a remarkably high risk for developing very aggressive breast and ovarian cancers, and often at a much, much younger age.
Okay, Section 4, Screening and Symptoms.
Here's the tricky part. Early-stage breast cancer is almost always completely asymptomatic. You won't feel a thing. That's exactly why screening is absolutely your best defense. For people at average risk, major guidelines recommend starting annual screening mammograms somewhere between age 40 and 45. But for high-risk patients, like those with a strong family history or a BRCA mutation, doctors get way more aggressive. Screening for them might start with an annual breast MRI as early as age 25, and then they'll start layering on annual mammograms at age 30. The absolute goal here is catching those tiny microcalcifications or masses way before they can ever be felt.
But what if symptoms do actually pop up? Well, a typical presentation is a painless, firm, palpable mass, and it's most commonly found in the upper outer quadrant of the breast. Sometimes the tumor actually tethers onto the suspensory ligaments, physically pulling and causing the skin or the nipple to retract. Now, contrast that with a rare but seriously terrifying variant called inflammatory breast cancer. This one doesn't even present with a distinct mass. Instead, tiny tumor microemboli completely clog up the dermal lymphatics. The fluid backs up, and the breast becomes swollen, red, hot, and painful, with the skin dimpling that literally looks exactly like an orange peel. Tragically, because it looks so much like a standard infection called mastitis, it can easily be misdiagnosed, which delays treatment until the cancer is already pretty advanced.
Let's move into Section 5, Decoding Subtypes.
Modern oncology is essentially a massive, high-stakes matching game. When doctors biopsy a tumor, they test it for 3 specific receptors to figure out exactly what's fueling its growth. If a tumor overexpresses estrogen or progesterone receptors, we call it hormone receptor positive, and doctors can treat it with drugs like tamoxifen or aromatase inhibitors to basically starve it of those hormones. If it overexpresses the HER2 growth factor, they'll use a targeted drug called trastuzumab. But what if it lacks all 3? That's what we call triple-negative breast cancer. It's highly aggressive, and because it lacks those specific targets, doctors have to rely heavily on broader weapons, like chemotherapy or immunotherapy. Finally, Section 6, Modern Treatments.
A patient's treatment plan today is an incredibly strategic, multi-phase operation. It very often starts with neoadjuvant therapy. That means giving chemotherapy or targeted drugs before surgery to actively shrink the tumor and clear out the lymph nodes. Next up is surgery itself. This could be a breast-conserving lumpectomy for smaller tumors, or a full mastectomy. But the battle definitely doesn't end in the operating room. Step 3 is adjuvant therapy. This involves using radiation or systemic drugs after surgery to hunt down and completely destroy any microscopic rogue cells that might have been left behind. It's all about aggressively preventing a recurrence.
And one of the coolest new weapons in this fight involves literally waking up the body itself. As the Mayo Clinic perfectly puts it, cancer cells blind your body's natural defense systems. Immunotherapy pulls off those blinders so your body's natural defenses can do their job. Basically, some of these tumors express proteins that actively shut down or attacking T cells, but breakthrough immunotherapy drugs physically block that interaction. They essentially wake the immune system back up so it can beat back the cancer cells entirely on its own. It's a real game changer.
Beyond what's already approved, there is just a massive wave of innovation happening right now. Get this, at any given time, there are more than 1,700 clinical trials for breast cancer treatments underway around the entire world. From new genetic targets to advanced immunotherapies, these trials they're the ultimate gift of hope. They give patients access to life-changing and potentially curative therapies years before they ever hit the broader market. So what should you really take away from this explainer today? Honestly, it should be a sense of profound optimism. Yes, the statistics are definitely daunting. And sure, the cellular biology is incredibly complex. But our medical toolkit has literally never been sharper. With survival rates continually rising and global science rapidly unlocking the absolute deepest genetic secrets of our cells, we really have to ask, what newly discovered treatment sitting in a lab right now might just become the universal cure of tomorrow? Thank you so much for exploring the science with me today.